Hello, everyone, and welcome to this episode of Medtech POV, the podcast brought to you by AdvaMed, the Medtech Association. I'm your host, Scott Whitaker, President and CEO of AdvaMed. Today, we're pleased to be joined by Lishan Aklog, Chairman and CEO of PAVmed and Lucid Diagnostics. An accomplished innovator, Lishan has experience in the operating room, the classroom, and the boardroom, and is an active, insightful member of our board as well. Lishan, welcome to the podcast. It's good to have you.
It's great to be here.
So you just came back from the Hill. You were here testifying at the Small Business Committee about sterilization, I think, right?
How do I look? Not too much.
You look great. You didn't take too much of a hit.
Exactly.
So.
No, it was really a great experience. It was interesting because there are multiple overlapping issues that were discussed, and our goal was to make sure that our issue was, got the attention it deserved. And so I thought it went really well.
Yeah, this issue of sterilization is a real challenge right now, right? I mean, EPA has this rule that's pending. The intent of it is probably well-intentioned, but the reality of the way it's drafted right now will cause real problems in the healthcare system.
It's a looming catastrophe. I mean, I think and we're just a few weeks away. My understanding is from the final rule potentially coming out. And so, as you said, updating regulations for ETO, that there's no, the industry as a whole supports that. There's no issue with that, but it has to be done right. And it has to be done in a way where the cost benefit is laid out clearly. And right now, as it's contemplated or drafted, the potential impact to the healthcare system as a whole could potentially be catastrophic. And that was really the goal of the hearing, was to raise that alarm to the legislators.
There's just not enough in the form of alternative sterilization modalities right now to replace ethylene oxide. And if you try to replace it in the short term, the likelihood of shortages or hospital infections because of non-sterilized products goes up tremendously. And that's it's a very high risk to take right now, I would think.
In the blink of an eye. I mean, 50% of the 20 billion medical devices that are used a year can only be sterilized with ethylene oxide.
Yeah,
and it's not for lack of, look, this is, this is an industry that, is constantly innovating. It's not for a lack of interest or in advancing these technologies. They just don't exist. The ethylene oxide has emerged because it's a gas, because it can find its way in through different internal parts of our very complexly assembled devices. It's currently the only option. And obviously we support, and companies within our sphere are working on alternatives, but just not exist. And you cannot just take half of the medical devices in this country and take them offline or impact the supply chain, their supply chain in any meaningful way without potentially catastrophic results.
And it's so important, Lishan, for the EPA regulators and then folks on the Hill as well, where you were yesterday, to hear the perspective of someone like you, who's a surgeon, but also an innovator and understands the importance of both. And it's what we do as an organization, and it's why we're so grateful that you're a part of it and you're willing to make that case, because it's one thing for me to say it, it's another thing for you to say it, and we need both of those voices.
It's great to have the opportunity to talk about it from those multiple hats. I was able to talk about experience with inserting artificial heart valves. Happens about 1 million times a year, and those are life and death. And having a heart valve infection is often a fatal event, and so you have to have perfectly sterile technologies, and we don't have any other way to sterilize them at this point. And I also had the opportunity to talk about an experience, sort of an interesting experience we had with my company, with Lucid Diagnostics, where we have a simpler device, the cell collection device, EsoCheck, that is really remarkably elegant, simple, deceptively simple device that allows us to collect cells for precancer testing. And we got that cleared when we did the sterilization validation with the FDA according to their standard models. It was fine. The FDA has very clear, established ways to validate that the product that you're selling is sterile. And we went through all that. And what we found when we commercialized it is that we're at the bottom of the ecosystem here, that there's a limited capacity for sterilization, and we were constantly battling to stay in line to get access to this. And we had times where we were really at very serious supply chain issues with this technology because we couldn't get it sterilized. And so we, as a small company with limited resources, we finally made the decision that this was risky and it could actually hurt patients and interfere with our ability to grow. And so we spent the time and resources to resubmit the device for FDA clearance as a non-sterile device, because it's something you swallow. It's not implanted. So that's an example of how tenuous the supply chain is right now, the sterilization capacity is right now. There is no reserve right now. And so any regulation that would cut that in any way without a reserve just has potentially catastrophic effects. And it's also concentrated. One of the things I was able to point out, for example, in the heart valve space is that the vast majority of heart valves are sterilized at one facility. And so it's not just the global sterilization, across the country, but in that one facility, the vulnerability that we have of that one facility was temporarily offline. Some of these are emergency procedures.
For sure.
It's not like there's inventory stocked up that can manage supply chain disruption, for any period of time. So it's a very serious issue. Hopefully they heard that, and there'll be an opportunity to do what we've asked them to do, which is for FDA, EPA, industry to work collaboratively to get these updated rules right.
And as you know, FDA is where we are on this issue. It's not just industry saying it. It's not just you and I saying it. It's what the FDA regulators are saying to EPA as well. So they need to have that dialogue, and they really need to get it right to avoid a catastrophic outcome. So we're grateful you were willing to weigh in for us on this one.
Yeah, it was fun.
Good.
Enjoyed it.
So it's Heart Health Month.
That's right.
And awareness of all the progress we've made over the years. You are a surgeon and also an innovator. Talk to us about your path to becoming a doctor and then becoming a cardiosurgeon.
All right, I'll try to keep it short, but I wasn't actually planning on being a doctor. My father was a prominent cardiologist in Ethiopia, and everyone assumed that I would just follow in his path, but I was kind of a math nerd, science, physics, and I thought I was going to be a particle physicist. But I got to college and realized that I wanted the opportunity, the corny thing, to help people, and so I transitioned there. And once I got to medical school, again, I had no notion that I would be interested in surgery. And usually the way you get into this is you first get the surgery bug and then you decide what to do. And I got that in spades. You do your rotation in your third year of medical school. My first rotation was my general surgery rotation, and they have you up all night on call. And I think we did 6 appendectomies the first night.
Wow.
And I woke up that morning and was like, that's what I want to do. That was cool. And then you sort of, a couple of years later, I got to rotate on some cardiac services, and the cardiovascular system is fascinating. It's got physics in it, right? It's really a pump and flows and trying to get blood in various parts of the body. And it has a bit more of a mathematical and a technology bent. And I think we'll probably touch on this later, but it's a very technology intensive part of medicine. And so I naturally gravitated to that.
So you ended up kind of following your father's footsteps anyhow, even though you didn't intend to.
But he was a cardiologist. He was a medical doctor. I ended up being a surgeon. And,
but you're still connected to the heart, right? A doctor connected to the heart, which is great. So, and how long did he practice medicine in Ethiopia?
He practiced for about 40 years. Yeah, really interesting. He trained at the American University of Beirut, and there was this cohort of physicians that dominated medicine in Ethiopia who were trained at an American university in Beirut. He did his residency here and kind of dominated medicine for 40 years. There was really great doctors that I had, people I could look up to.
Wow, that's
there.
Great. Mm-hmm. Yeah. So I wasn't going to cover this, but I'm intrigued by it, so I'm going to ask it anyhow. What was practicing medicine like in Ethiopia for your father versus what it's like today practicing medicine in the U.S.?
Oh, it's absolutely amazing. I mean, I think back, because I was just a young kid, I think back at, he was revered, and people, he would get called in the middle of the night and go help people and so forth. I was really proud of him. Right. But I think back now, what tools did he actually have? He actually inserted the first pacemaker.
Is that right?
In Ethiopia, which was pretty remarkable, because that was in the 80s, and pacemaker technology was just getting started.
Right.
But for the most part, he had his little black bag, and he had a variety of fairly straightforward medications. It was good old-fashioned diagnosis and so forth. And an interesting twist here, which is that when I came to this country, the way I ended up here was my father took care of a missionary, a Lutheran missionary. I went to a Lutheran missionary school who had a heart attack, and he took care of him, and he did fine. And the pastor, the minister said, what can I do for you? And he said, you can help me get my kids out of the country. That's what you can do.
Wow.
And so he contacted his sister, who was a parishioner at a church in suburban Chicago, and ultimately worked out for me and my sister to leave Ethiopia and come here. The reason that's interesting with regard to your question is that now I think back and I say, well, what did my father actually do? 1979 in Ethiopia, there's no cardiac catheterization, there's no particular imaging. I mean, he gave him aspirin, presumably, and just kind of monitored him and just made sure that he recovered. And so at the time, it was like he saved his life, and he presumably did. But now I think back at sort of what, like to your point, what we have in terms of technology today versus what it was like to practice then.
Yeah, it's interesting. I'm curious how far behind Ethiopia is with the cardiovascular technology, the access to cardiovascular technology. Have they caught up now?
Not quite, but there's been some progress recently. And it's an interesting dynamic. I think the interesting question there is you have a country that's low on resources, that has still lots of traditional public health issues, cholera outbreaks, things like that, that need resources and attention. And there's always been a bit of a struggle as to, do you put in capital-intensive resources like heart catheterization and surgery and things like that in that context. And there's always been a little bit of a ethical question around that. One of my mentors who I trained with in London, an incredible guy named Sir Magdi Yaqub, actually started some of the original heart surgery in Ethiopia. So there is heart surgery in Ethiopia right now. There is cardiac catheterization. You can get access to that, but it's limited and it's still challenging to decide where to allocate those resources.
Some of those resource issues you have in Ethiopia are also present in the U.S. as well, maybe at a different scale, right? Because if you look at underserved community, a lot of minority communities, they don't have the same access to the technologies that oftentimes the wealthy do, right? And what is the reason behind that, and what are the biggest hurdles to helping get better cardiology treatment into those communities as well?
I think there's a variety of factors. I mean, some of them are just more of the core economic factors, right? People in those communities have poorer health. They don't have access to healthy food. They're food deserts, so to speak. There's lots of diabetes, lots of hypertension, so there's more of it. And the medical centers and the medical community that serves them are under-resourced, right? So if you have, the classic example which we've mentioned, if you think in sort of LA, there are two hospitals right very close to each other, almost across the street from each other, and one of them is the community hospital that caters to the local minority community, and one caters to a very wealthy Hollywood types. And the technology that's available and the difference between those is stark in terms of access to new and modern technology. Some of it relates to reimbursement, and we've touched on this before, which is that if there is a differential with regard, if there's insufficient reimbursement by the public funding entities, Medicare, Medicaid, then you're going to naturally end up with inequities because the wealthier hospitals can offer modern technologies early at a loss, sort of a loss leader, so they can show that they're cutting edge, while the hospitals that cater to underserved communities just can't do that.
Talked about some of the underlying causes to cardiovascular disease, particularly in low-income communities. What are some of the things? I mean, you're a doctor. If you were giving advice to people who live in those communities, what are some of the things they can do to help prevent the progression of cardiovascular disease?
It really starts with just lifestyle issues, access to the ability to exercise, access to healthy foods. It's very well understood what types of nutrients, what types of foods actually can contribute to heart disease, saturated fats, trans fats, and so forth. But that's easier said than done, right? Because in those communities, again, there's sort of these food deserts where people don't necessarily like to go to fast food every day, but there may not be options to get access to healthy, nutritious foods, vegetables, fruits, and other things. The second part is really, really dominant now is the explosion of diabetes and pre-diabetes. We talk about diabetes as sort of this threshold thing, but it's really a continuum from the whole metabolic syndrome, so to speak. And so that's rampant, that's epidemic. And so that, being in a position where you can control that hypertension, very poorly controlled in those communities, very sad because we obviously have lots of good ways we can treat hypertension. So from the patient's point of view, it's trying your best to get access to healthy aspects of your healthy lifestyle, but also for those communities to demand that they have those resources so that they can, on a population basis, have healthier communities.
What role does exercise and activity play in ensuring you have a healthy cardiovascular system?
A lot. So your cardiovascular fitness. So we sort of have we have traditional ways we look at that, which is that you have to go out and run 5 miles and so forth. But it starts with general levels of activity. We're a sedentary society. We sit at desks and do Zoom calls all day long, and that unequivocally contributes. So it starts with just having people be more active, doing some cardiovascular activity where even for short periods, several times a week, getting your heart rate above a certain threshold. So the bar is lower than most people realize. Most people think they have to go out and sort of run a couple of miles several times a week to get the benefits, but the benefits actually start to accrue with just even modest levels.
So if you eat fairly well, you exercise to some degree on a regular basis, you take care of your stress levels, I assume, and mental health to some degree too.
Definitely sort of there's a wellness component to this, that we're a stressed out society, and there's no question that there's a strong connection between the two. But one thing there is a medical aspect to this as well, right?
Yeah.
And so as much as we emphasize the lifestyle matters, I don't want to in any way diminish that. There are certain things that people can't control.
Right.
And sometimes I find it frustrating that family members and others will say, well, I'm just going to eat better. I'm going to exercise more.
Right.
And you're like, yeah, but your bad cholesterol, your LDL is 180. You just, you can only have so much effect from that. And we should be taking advantage of the fact that we understand the biology and there are actual medical interventions we can take. And so there's nothing wrong with, that doesn't detract from the fact that lifestyle actually is important, but we shouldn't ignore the fact that there are things we can control. So it's called a lipid profile. We think of it as cholesterol. The main bad actor is your bad cholesterol, your LDL, and that should be under control. And it probably should be lower than maybe even most doctors consider. Blood pressure, and then there are other measures that your doctor can take a look at.
Yeah.
But we can't forget that. And I find that sometimes people try to think that they can lifestyle away some of the more core biologic processes.
There are certain genetic connections to heart health as well, right?
That's correct.
That you just either are born with, you're not born with, that help either control your cholesterol or your heart rhythm or a variety of other factors as well, right?
That's exactly right. So you can have somebody who's otherwise healthy, they're active, they exercise, they eat well, but they have a genetic predisposition to a high cholesterol. And that can result in heart disease. My family sadly experienced that. My mother had multiple brothers who had heart disease at a young age and in Ethiopia, and many of them died before the age of 60, at a young age. And so there's a genetic component to it. So people should take that in consideration as well.
Talk to us a little bit about the progress that's been made in heart health. You talked about cholesterol. Obviously, pharmaceuticals, biologics have helped reduce the incidence of bad heart disease. But there's also a lot of Medtech interventions that have occurred over the course of the last 15, 20 years that have been transformative too. Talk about the progress we've made.
I think
there.
I'll come up with one, and this when we could focus on this perhaps. And it relates to this connection between prediabetes and diabetes, right? Which is that there are a lot of people who don't reach the threshold of being formally defined as diabetes, but they have this sort of broader metabolic syndrome. They're kind of overweight, they are obese, a variety of other measures that form this thing called metabolic syndrome. And one thing that they have is a abnormal A1C, which is sort of the level of that measure of your blood sugar, but you don't reach a stage of diabetes. There's a lot of interest right now in monitoring your blood sugar, even if you're continuous monitoring of blood sugars, even if you're not a diabetic. And so there's several continuous glucose monitors. They have a little patch on. I'm wearing one right now that can give you really useful information on your blood sugar, and it can be excellent feedback that allows you to make more healthy decisions and do so in a personalized way.
Right.
It's one thing to tell people you should lose weight, you should exercise, you should eat more, kale or whatever. And but those are general kind of population-based things, and everybody's biology is a little bit different. And so one thing MedTech can do is really provide people with information that's tailored to them and that's timely, that's really connected to their actual decisions that they're making in their life, so they can make modifications accordingly. And so the CGM monitors, continuous glucose monitors, are one way of doing that. And there's a lot of interest in moving access to that from diabetics to patients who are pre-diabetic and have other factors. And it's really remarkable. And that kind of folds into another area, which is digital health.
Right.
We have the ability, again, same thing, give people information, monitor the various aspects of their physiology and their physical parameters, and give them that information so they can make better decisions, as opposed to just showing them charts of what they should be eating and not eating.
Yeah. The CGMs are particularly fascinating, and I'm glad you talked about that, because there are a lot of prescription options out there, or new service options out there for people who aren't diabetic to get access to these tools as well.
Correct.
To sort of test and see what your blood sugar levels are throughout the day. Yeah. I've tried it out before as well. My daughter's a type 1 diabetic, so I've tried her CGMs before. And it is fascinating what certain foods do to your blood sugar and the impact that has over the course of the night, for example.
Correct.
If you eat badly in the evening and it stays in your body for a long time. It's those high levels that can really impact your heart health tremendously.
Yeah, we're still understanding obesity. We're still understanding the metabolic syndrome. But what it appears to be is that the simplistic calories in, calories out sort of analysis that we've done is really, really very limited in its ability to inform us, right? So there are some subtleties there. And the CGM example is that if you have spikes in your blood sugar, even if you're not diabetic, then your body responds by pounding you with insulin. And the long-term response response to that is you become more insulin resistant. That's just sort of a natural thing your body does.
Right.
When it sees a lot of something, it becomes resistant to that stimulus. And so that's how you develop insulin resistance. And that develops into a vicious cycle of more obesity, more insulin resistance, and you work your way and ultimately can culminate in full-blown type 2 diabetes. So having that information, I used it, and they're very subtle things. Like the same food eaten at 7 o'clock at night versus 11 o'clock at night can have a dramatic effect on your blood sugars overnight.
Right.
The order, whether you incorporate a little bit of protein and fat with some carbs versus just having a pretzel in the afternoon on an empty stomach, very dramatic differences. Right. And you can't tell people, you can't educate people on how to do that with just population-based recommendations.
Yeah.
Having them have their own information in real time actually works.
The other thing that was fascinating to me is the impact that exercise has on your blood sugar, and vigorous exercise on your blood sugar. It can really drop and burn off sugar like I'm not sure I fully appreciated the dramatic effect it can have.
You bet. It relates to sort of complex biochemistry of how glucose is stored in your muscle and so forth. But at a high level, I think it's not surprising that having timely information, people want to. People want to get healthier.
Right.
There's a stigma often attached with obesity or with other, that it's a matter of willpower as opposed to much more complex dynamics that are going on. People want to get healthier, and so we can in MedTech offer them tools so that they have the information that relates very closely to the underlying biology and understanding of that so that they can get healthier.
You talked about connected health and its benefit to heart health. You talked a little bit about the CGM specifically, digital health as well. What are the other things that are coming, in your view, that are really going to improve heart health and then heart treatment as well?
Certainly on the treatment side, MedTech is right at the forefront. Certainly you can, on treating high cholesterol or ones that are refractory or your blood pressure and so forth, the forefront of that will probably remain therapeutics. But once you start developing signs of heart disease, then MedTech has done remarkable things to date and will continue to do so. So it all starts from imaging, our ability to make an early diagnosis and identify people at an early stage so interventions can be taking place. Once there are blockages to the arteries to the heart, we have the ability to treat that with modern day catheter treatments, stents, balloons, and so forth. If you reach a point where there's damage to the heart and the heart is starting to fail, we have incredible technologies, assist devices, artificial hearts, artificial valves. If the valves dilate, those can be done. It's remarkable. When I trained over the years, we did open heart surgery for valve replacements. Now they're being done. The majority of those are being done using catheters. So there's just there's been an explosion of technologies and just more along the way. There's one interesting one that I didn't mention, which is I did say that most of the time treating the risk factors such as hypertension is likely going to be done with medication. But just this last it was about 4 months ago, there are 2 new technologies that were cleared for something called renal denervation. And this is a way to treat high blood pressure, particularly those who have really refractory. They're on 3 or 4 medications that can't get their blood pressure down by threading a catheter into the artery to the kidneys, into the renal artery, and buzzing, basically ablating nerves that go to the kidney that are overfiring to the kidney that are altering the physiology. And those devices have been shown. Now, it's been a long haul. It's been almost 20 years in development since the first attempts at doing this, that if you ablate those nerves, if you sort of interfere with the nervous stimulus to the kidney, you can dramatically improve these patients who have refractory hypertension. So there are 2 devices. Medtronic has one, and a company called Recor has one that were the first 2 that were just cleared a few months ago. We're just scratching the surface of understanding who the right patients are. Clearly severe ones, but you start with the highest risk, but it very well may be that we may learn in the next 5 to 10 years that we can cure hypertension with a procedure so people don't have to take medicines for the rest of their life.
Is it similar technology to the ablation technology for arrhythmia and
it's the same underlying biology, right? So you're heating tissue and trying to essentially in a very targeted way destroy certain tissues. So for the heart, you're trying to destroy abnormal electrical pathways that cause jumbled abnormal rhythms in the heart.
Yep.
In this case, you're trying to selectively destroy nerves that are transmitting signals to the kidney and causing the kidney to do all sorts of abnormal things with regard to how it manages salt and things like that.
Right.
And so, very similar. One of the technologies uses radio frequency, which is a way of delivering energy. to give you a targeted ablation, targeted destruction of certain tissues, and the other one uses ultrasound. Same thing. You just you deliver some energy in a very focused place, and you interfere with the conductivity of the nerve there, and you have a physiologic effect that has a benefit to the patient.
Yeah, that's fascinating.
Yeah, cool.
Staying with the blood pressure theme, because you mentioned this a couple times as we've been talking about heart health. One of the challenges with blood pressure is monitoring blood pressure.
Correct.
Is there progress being made to continuously monitor blood pressure in a way that you get a more accurate reading of it and its impact on heart health?
It's a great question, and it's an interest of mine, because if you think, you go to your doctor's office today and you get your blood pressure checked, the term for that device is a sphygmomanometer. It's a mouthful, right? And it's just a rubber bladder that wraps around your arm, and he's got, these days you don't have to listen with a stethoscope, but fundamentally the core of that technology is from the 19th century. We really haven't made much progress in that in over 100 years. And so the holy grail has always been, it's a spot measurement, right? That's a spot measurement. At one point in time, there's this thing called white coat hypertension.
Maybe you're stressed out when you go to the doctor.
There's an actual term for it. It's called white coat hypertension, which there's studies on it where we can't even use that data point. It's not all that helpful because it's not it doesn't clearly show what you have over the just day to day, right? And so continuous blood pressure monitoring has been difficult with that technology. You can imagine if you have people do walk around for 2 weeks with essentially a blood pressure cuff on that's inflating and deflating constantly to try to get a sense as to what their blood pressure is during the day. So you're right. The need to take our modern technological wizardry and create and be able to monitor something as simple as the blood pressure in your arteries has been, in a sense, a holy grail for a long, long time. And we're starting to see advances there. We're not there yet. There are some, folks that sort of are touting that they've cracked the code and you can put a little thing on your finger or even on your watch can pick up your blood pressure. None of those have quite crossed the threshold. It's a hard thing to do. In the hospital setting, we have made progress. There are some companies out there that are marketing devices. One's Caretaker Medical that has the ability to measure blood pressure with a non-invasive, just a little thing on your finger, almost like an oxygen saturation probe.
Wow.
But the day when we'll have that happen, when just your watch or some other patch can measure your blood pressure, they're coming. They're not just here yet. I would be shocked if in 5 years all of our watches won't monitor our blood pressure, and that'll be a huge boon to this. It'll take some time to figure out what that means, right? Because sometimes you get a lot of data.
Fluctuations are dramatic,
exactly.
right?
Yeah, you go exercise.
When
you go exercise, your blood pressure can go high, and in the recovery phase, it can go low. So we'll have to, once we have this barrage of data, we'll have to understand exactly what to do with it. But more data is better than less, and so we'll be able to have an impact, I think.
So given the uncertainty about blood pressure that individuals may have, but the importance it has on heart health, what advice would you give someone who has a bit of a blood pressure issue when they go to the doc? How do they monitor that in a way to ensure that they're not spiking too often? What's the recommendation?
First of all, find a good doctor. It's important to have somebody who takes these risk factors and these issues seriously and is making a concerted effort to get you better. So, and you basically work with your doctor, but there are things that you can do at home. And if your blood pressure is high and it's above, there are very clear criteria. People can look it up on the internet. The American Heart Association and others have very clear criteria. You have to remember it's both the upper number, the systolic and the diastolic are both important. And then to work with your doctor to make adjustments to your medications to make sure that it's under control. There are home blood pressure cuffs. I recommend them. My mom has one. She measures her blood pressure regularly and reports to me. And it's important to do research on those. There are some that are FDA clear. There are some that are not so accurate. And it doesn't have to be terribly fancy with all sorts of digital wizardry and Bluetooth and things like that. But you measure blood pressure at the same time every day, in the same position every day. You can track it. There are lots of smartphone apps that help with that. And then you communicate with your doctor and your doctor should be making subtle adjustments to your medication until you're in a steady state. You don't want that. You just need to end up in a steady state. So it takes work on both the part of the patient and the doctor, but it can be done.
But daily rigor, if you have it in your family, you have a family history, test it?
I think
once
so.
a day
There's some danger in
sleep?
recommending that, and that people over test and then they get kind of worked up, and it can have a certain
can
cycle.
Increase your blood pressure
yeah, exactly
right. There, right?
So I think during a period of time when adjustments are being made and you're trying to end up in a steady state where you're on a stable combination of medications and your blood pressure is holding. Once it's stable, once you're in a kind of a steady state, then it doesn't necessarily have to be every day. It can be, once or twice a week or something like that. I do worry that people get overly obsessed and are measuring it a lot, measuring it too much, for example.
Yeah. Well, it's been a fascinating discussion on heart health. I want to transition to cancer because we've made tremendous strides in treating cancer over the course of the past 10 or 15 years as well. One of the things you and I have talked about is the importance of early diagnosis. And you've got a technology in this space. I want to give you a minute to talk about that and the importance in catching cancer in early stages to avoid really negative long-term outcomes.
So the concept of early detection is one that's well established. It makes sense to just even a layperson, right? If you pick something, cancer is a progressive process. It starts with some abnormal cells, and then it can progress and ultimately ravage the body, right? So the goal is to identify things as early as possible, but that's not enough, right? If you detect something early, then you have to have something you can do about it that can actually alter the course. And that's a subtlety that often is lost, right? Picking something up early doesn't necessarily benefit a patient unless you can do something about it. So that's what constitutes an early detection program, right? You know who the target population is, who's at risk. You know that you have ways to detect it early, and then you have something you can do about it to prevent progression. So we have clear evidence that works and that saves lives. So the classic examples are mammography, right? So Pap testing. Those two, for decades, we've lowered mortality rates for those two cancers by 50% or more as a result of early detection in those two cancers. And the same with colon cancer. Colonoscopy, the compliance rates are quite high. We have stool DNA testing, which can supplement or replace colonoscopy in certain circumstances. And so we're doing pretty well with those three. But that's just three, and it falls off quite dramatically from there, right? We know that smokers get lung cancer. We know if a smoker gets a CT scan, a so-called low-dose CT scan, that we can decrease mortality rates, but the penetration, their compliance rates with that are very low despite strong recommendations. All the other cancers, nothing. We don't really have, historically, we haven't had other programs for early detection. And so that gets to what you're referring to, is that we're very active in this space. If you think of the three deadliest cancers, it's pancreatic first, and then a close sort of tied for second are esophageal and liver. And those three, you sort of call them the deadly three GI cancers. The deaths from that are greater than deaths from colon and breast cancer, when we don't talk about them.
Is that because of detection, early detection?
Yeah. The number of cancers, there's more breast and colon cancer than these three. But we're doing a pretty good job of picking them up early and intervening and decreasing mortality rates. But for these three, we have nothing. We've historically had nothing. And so more people die of those three cancers than others. Of those three, we now have a crack at one of them, which is esophageal cancer. So esophageal cancer arises in patients typically who have heartburn, reflux, where acid and other stomach contents find their way into the lower esophagus, and they cause changes, abnormalities there. And the interesting thing is that those changes can happen even if you don't have symptoms, or if you take your over-the-counter medications, Nexium, Prilosec, and you actually don't have symptoms anymore. It's still the underlying biologic process is still clicking away, and that can eventually work its way through a precancerous phase to esophageal cancer, which is incredibly deadly. And 80% of patients die within 5 years. It's effectively a death sentence. And the one even worse characteristic is that even at stage one, it's got a 50% mortality.
Wow.
So a stage one breast or stage one colon cancer, that's no, we don't, obviously that's terrible. That's a terrible thing to be diagnosed with, but the cure rates there are 90% or above. For esophageal cancer, even if you pick it up at stage one, it has a 50% mortality. So what does that mean? That means that if you're going to have an impact on esophageal cancer, which there are 16,000 people die a year, you have to pick it up at the precancer stage. Now, that's harder biologically, right? Because cancer cells are pretty abnormal. So you can pick up little subtle changes in the DNA circulating in the blood and so forth. When you're trying to move upstream to the earlier stages, it's much more tricky biologically to pick that up. But the great thing is if you can pick up a precancer, then you're doing something even better than what you're doing with these other cancers, is you're doing cancer prevention. So early cancer detection is great, but what's even better is cancer prevention. And so So for esophageal cancer, we actually have to do cancer prevention.
Okay.
And so what is now available is really sophisticated molecular biologic techniques that can detect very subtle changes in cells in the esophagus. These are epigenetic changes. So they're not mutations, they're not sort of things that are happening in the nucleus, but epigenetic changes to the DNA. And those subtle changes can be picked up with modern day molecular techniques, with modern day sequencing techniques, and identify patients with the earliest stages of precancer in a non-invasive way. So what the technology that we've worked with Case Western Reserve University to bring to market, there are two elements of that. One is EsoGuard, which is this molecular diagnostic test. It sequences things, and we have the ability, I don't know if people appreciate this, to do DNA sequencing in record time. I spent 4 years in medical school on a project sequencing a little piece of RNA. Literally every weekend I'd be there. Now we can do what took me 4 years of medical school in our lab in an hour.
Wow, amazing.
It's amazing technology. It's called next generation sequencing. And so with that, armed with that medical technology, we can take a cell and say that cell has a precancerous change. But how do you get that cell? It's not in the blood because it's a precancer. You're not going to get precancerous changes circulating in the blood. So you actually have to go get the cells. And the cells this area is in the lower part of the esophagus, just above the stomach. And the question is, how do you get those cells? Historically, you have to do an endoscopy. An endoscopy takes, 2 people have to take the day off work, anesthesia, sedation, so forth. It's a big complex thing, and it's hard for people to convince people to do it. And so the same physician scientists invented this very clever tool called EsoCheck, which allows you in an office in 2 minutes or less to swallow this little capsule on a tether that has a balloon on it that can target it in a targeted way, sample that just 2 inches of the lower esophagus without any cameras or endoscopy or anything like that. Just 2 minutes with no anesthesia in an office. Now you have the cells. You can do this crazy, sophisticated molecular NGS technology, and you can say, okay, this patient has an early stage precancer. We know it with 80+% sensitivity, and then we can say, like I mentioned before, now you have to say, what do you do with that? Right. So now what do you do with that is perfect. Now you have an early stage precancer. Okay, nothing really to do there. You just monitor them. So they get an endoscopy every 3 years, and you're trying to pick up as it progresses from an early stage precancer to a late stage precancer, but not yet cancer. And then when you get to the later stage precancers where you start seeing these changes called dysplasia, then you can come in and do what? Ablation. So we're coming back to a common theme here.
Okay.
So you can actually destroy those abnormal cells before they develop cancer, and therefore you can reliably prevent the progression to cancer. So that's cancer prevention, which is now available. So now we have we have both technologies. They're commercialized. We're testing thousands of patients a quarter. We're focusing on firefighters because they have a particular elevated inclination there, and there's a lot of opportunity to have a big impact suddenly. And it's all about technology.
That is fascinating. Are you seeing any similar progress in pancreatic or liver cancer in early detection?
Not yet. Not yet. So there are some tests that are in progress that are being evaluated, but nothing has broken through for either of those, and we need to. The problem with pancreatic cancer is that unlike with esophageal cancer, you don't have this thing, GERD, heartburn, where you can say, okay, we're going to take the people with heartburn, and you've got these risk factors. The population is very well defined. Like I mentioned, if you're going to do an early detection program, you have to say who should be tested, and identify that group clearly. That's one of the challenges with these multi-cancer blood tests. Like, who are we going to test? Fine, you have a blood test that maybe can pick up cancer, but you don't really. It's not a well-defined population. So pancreatic is hard. We don't have as clear a picture as to who we would test. Liver, there clearly are liver patients, patients who've had hepatitis or have other types of liver disease that you can target, but nothing is yet broken through. But there's hope, obviously, that the similar types of technology could break through for those. And
no specific blood tests that can detect cancer earlier in pancreatic or liver?
Nope. I mean, these multi-cancer tests do show. It's amazing, just to be clear. I'm not here to trash it, because you're literally picking up a couple of molecules of DNA in a blood sample and being able to make some assessment biologically of what's going on, which is an incredible breakthrough. The problem is that for the ability, the sensitivity of these tests tend to skew towards the later stages. So you're picking up 3 and 4, where you're not necessarily going to have an impact of picking up those later stages. So the holy grail is to be able to say, we can pick up stage 1 cancer with a blood test reliably in a population that we can identify. And we're not there yet, but the technology might get there. It just gets harder. The earlier you get, the less abnormal the cells, the less abnormal the DNA. And once we get there, then we'll still have challenges about identifying the target population. And then you have to also work out, it's not as easy as just saying, I found cancer in the blood.
Right.
Where is it?
Right.
And so sometimes they can say, you have cancer and we think it's this, and direct the physicians to go down a path. Sometimes not. But that leads to sort of a lot of imaging, that leads to a lot of biopsies, that leads to a lot of false positive biopsies. So there is kind of downstream consequences to that. It's an incredibly promising field, but there's still a long ways to go before we figure out how to handle that. What we have for this particular, I still think the immediate future is going to be specific cancers. So we think we've cracked the code for esophageal. So hopefully someone will follow suit on pancreas, on liver, and we'll just sort of chip away at these deadly cancers like we've done with breast and colon. That, I think, is the more immediate opportunity. Whether we'll land in a situation where we can truly do a single blood test and it'll just tell you, like in Star Trek, what you have. It'd be nice, but I think that's still a ways away.
Yeah. Let's transition to AI for a minute and its impact on imaging technology particularly. I've heard a lot of people talk about the value of AI in imaging, the ability to get better images, better feedback, better information in order to diagnose with more precision and much earlier. Is that the case in other forms of cancer diagnosis as well?
It will be.
Are you beginning to see that yet? Or?
It will be, and we are beginning to see that. But you're right. The impact on imaging, so radiologic imaging, as well as pathology, is already remarkable. I mean, we're getting to points where AI algorithms can pick up subtleties on radiologic imaging and on pathology that trained physician eyes just can't see. And so that progress is going at a breakneck pace. But we're seeing it in other areas as well. So many, if not most, of the molecular diagnostic tests that are coming along have some AI-built algorithm into it, where there's some machine learning. You look at this genetic sequence, you can correlate it to these abnormalities, and maybe there's some underlying biologic explanation as to why A implies B, but it doesn't really matter. If you have machine learning, you have an algorithm that can tell you that. And so that there is a lot of activity there, and essentially every test is trying to incorporate some level of AI and machine learning algorithms into it, but just scratching the surface there. It's remarkable.
In your experience, both as a doc and an innovator, are there federal laws or regulatory issues that become impediments or barriers to progress in cancer innovation or other areas?
I mean, there are always barriers, and the key is to try to hone in on them, what they are, what the alternative improvements are, and to work with the regulators to improve that. And I think, as you know, we've had pretty good luck with FDA in this matter. FDA has taken a proactive approach with regard to figuring out how to process and assess digital health technologies, and that appears to be a fairly collaborative exercise right now between industry and FDA. There are challenges on the diagnostic side. So, traditionally, the traditional structure by which devices are assessed by FDA make it difficult to iterate. Right? You have a device, and you're like, okay, I have another, next generation of the device. You've got to go through essentially a pretty substantial process to determine that that is safe and effective, right? But things like diagnostic tests or algorithms, so forth, can change weekly. Constantly updating, especially ones that are based on AI and machine learning. There's a constant updating process, and so the regulatory frameworks have to acknowledge that. And there is some activity right now that suggests that there is an openness to prospectively saying what version improvements can happen in these more data-driven tests. And so it's encouraging, but there's work to be done.
I'm going to back all the way up to the 70s. Richard Nixon was president, declared a war on cancer. We're a long ways from that now. If you had to assess where we've progressed and what the future looks like in cancer treatment, how much of that battle have we won, and what's the next few years look like?
Well, I think it would be premature to say we're winning, or we certainly haven't won, because cancer remains the second deadliest disease. It kills hundreds of thousands of people a year. But the progress that's been made in the last 10 years, as you said, is pretty remarkable. I mean, I have a family member who was diagnosed with stage 4 lung cancer 4 or 5 years ago. Even though I did heart surgery, I trained as a thoracic surgeon, so I knew immediately what that meant historically, which was that maybe 6 months, if you're lucky, no real surgical treatment options, things like that. He's still alive.
Wow.
And has pretty good quality of life. And so that's to me, kind of the best example of how much progress we've made. And we made progress on multiple fronts. We've talked about diagnosis. What's happening on the biotech pharma side is amazing with immunotherapy, CAR T, toll-like receptor. There's just our understanding of the underlying biology and our ability to target the processes of cancer we've made remarkable progress in that front as well. And there's an element that is that we've already touched on, which is more precision medicine. We talked about sort of precision medicine when it came to cardiovascular issues. Precision medicine is a central part of cancer care right now. So you will not get a treatment for your cancer without there being a very comprehensive genomic profiling using molecular diagnostic tests of a subtle abnormal. You don't just have breast cancer anymore. You have breast cancer with a whole slew of biomarker plus this, you're positive that, you're negative this, you're triple negative. There's all sorts of ways of characterizing cancers these days, and the treatments are being tailored based on these diagnostic tests. So even though the therapies, the biopharma therapies get all the attention, behind that is a lot of activity in the medtech space with regard to genomic profiling tests, and even afterwards, when we monitor them, there's something called minimal residual disease, or MRD tests, that facilitate monitoring patients after they've had their treatment and making sure that you swoop in after the fact. So the whole precision oncology, precision medicine side of things is a whole area within diagnostics that's having a big impact.
So we haven't won the war, but we've made a lot of progress, and maybe there's reason to be hopeful.
100%. Yeah. These breakthroughs are coming in at a breakneck pace right now, and it's remarkable to watch.
Yeah, it's exciting. Let's transition to health equity for a minute. You have taken over as chair of our Health Equity and Diversity Committee. I want you to talk about that from your perspective. Why is that an issue that's important to you personally? And then beyond that, what can we do as an industry to advance better equity in healthcare? Yeah,
it's been a real honor. It's been great. I've been really impressed, thanks to you and the leadership at AdvaMed's commitment to this issue. And there's a social element to it, of course. There's a social justice element to it, but it goes beyond that. I mean, if you think about technology, most of the technology that we have at some point can be traced back to basic research that happened at some place where government funds in some way, NIH funds or something, contributed to that. That's true for our tests. So both of our technologies were funded by National Cancer Institute grants at the academic center that developed them. So that's the people's money, right, at the end of the day. And so we have a fundamental obligation, if those technologies when they become available to the benefit of patients, that all patients have access to those technologies. We have a moral imperative to do that. It's also better for our society. We want people to be healthier, and having healthier patients, a healthier population, benefits all of us. So the impetus for doing this is clear, and everyone should agree that health equity is an imperative that we should all take seriously. How do we do that? That's the tougher question. The first thing is, how do you define it even? We think of, there's a fair amount of acknowledgement of disparities as it relates to race and to gender, right? Those are pretty well, I don't have to rattle off statistics, but in just about everywhere you look, Black people, African Americans tend to have worse outcomes, even if you control for socioeconomic status and so forth, with regard to essentially all interventions, but including most predominantly in the cardiovascular space. Same with women. A woman shows up with a heart attack, her outcomes are going to be worse than a male, and so those are the core two, but there are other areas of equity, whether it's rural versus urban. The outcomes in rural areas where access to healthcare, there's a lot of pressure on rural hospitals right now. It's very hard to make them work economically. So that's an area that we focus on as well. And there's age. It's important because the population over 65 is mostly covered by public insurance, and those under are mostly covered by private. That we make sure that distinction does not lead to differences in outcome related to age. So now that you've defined it, we have to go out and tackle it, and that's a matter of getting data and working and identifying what the drivers are that drive these inequities. A lot of them are regulatory and reimbursement, and working together with the appropriate entities to solve those.
To oversimplify it, Lishan, to me, health equity comes down to sort of two pieces fundamentally. Access to health care, which is one piece, whether it's health insurance or a doctor or health system. That's one piece of it. But then the second piece of it is access to health technologies that can help save lives or impact individuals' health. We talked about both of those to some degree. But earlier we talked about technologies.
Correct.
And the inability of those in certain communities, rural and some urban communities as well, to get access to those new technologies. What drives that lack of access, even when you have health insurance coverage, for example?
What drives it is that technology is developing, again, at a breakneck pace, and the regulatory and reimbursement governmental organizations have a hard time keeping up. And so the gap in time from the introduction of a breakthrough technology to it being widely available, and it being widely available depends on the proper regulatory framework, and in particular the proper reimbursement framework. There's a long time between those. From the time that, we talked about transcatheter heart valves. From the time that transcatheter heart valves were launched till they became sort of widely available at most hospitals across this country was over a decade. And for a large chunk of that early period, the wealthier hospitals were just offering them as a loss leader because their patients demanded it.
Right.
It was sort of necessary for them to do that, and that wasn't an option for others. So we need the reimbursement, whether it's private pay or governmental organizations, to acknowledge that there are breakthrough devices that can have an immediate impact and help patients immediately, and that they're reimbursed in a way that makes sure that all patients have access.
Yeah.
I think it's the biggest hurdle.
You talked about people over 65. You talked about people in the poverty area, right? Both categories are covered by generally government policies,
Correct.
Right? Medicaid and then Medicare. What can Medicare and Medicaid do to change that dynamic? Because the volume of people who rely on those programs is tremendous, especially with respect to need.
Correct.
Right? So what can those federal programs do to improve access, not to the program, but to the technology?
It's about providing transparency and predictability so that breakthrough technologies that can benefit patients urgently are reimbursed in a way that allows patients access to that. Right. And we don't have that yet. It's as a small company entrepreneur that's raising capital every day, for me to be able to raise capital, I have to be able to develop these technologies. I have to be able to tell investors that if we're successful, there's no guarantee that we'll be successful at getting through the intellectual property, actually developing the technology, actually being able to commercialize it, actually getting doctors to do it. There are all sorts of other risks. But the pot at the end of the rainbow has to be, if you're successful at all of that, then then you can make a business out of it. And to make a business out of it, payers have to pay for it. And the time and the cost to get to that point has to be reasonable and has to be predictable. It's really the predictability and the transparency part that's probably as important as anything. And we just don't have that. And there is legislation and there's efforts that we're, as AdvaMed, are obviously at the center of to try to get an alignment between the things that are designated by FDA as breakthrough to make sure that they have a clear path to being reimbursed, so that the ecosystem that funds the development of these breakthrough technologies can incorporate that and operate efficiently. Yeah,
if you don't get reimbursement for a product, or at least a process towards reimbursement, the likelihood of getting the additional capital you need to develop it is very, very difficult as well, right? And it's all connected, right? Not everybody understands the connected nature of innovation, from pre-FDA to FDA to coverage to patient.
I mean, investors are willing to take risks, but they understand that at each step of the way there's a risk that you won't be successful. That just gets built into the algorithm. But you have to know that if those risks are cleared, if those hurdles are cleared, that the final hurdle of actually getting it is a very odd. I sort of joke to my friends in other industries, like, can you imagine if you made cars and you made some new electric car and you had to essentially give them away for free, for some period of time until some organization kind of said, okay, now we'll start paying for it. And it's a very odd thing. I mean, we have right now we have a test that we have very strong data on. We know it works. I'm not whining here. I'm just saying it's an odd struggle. It's not the way you would design this. When we're essentially have to subsidize through capital that we raise, delivering this technology to patients while waiting for the creaky system of reimbursement acknowledging the value of this to catch up. It's a very strange structure we operate in.
To me, reimbursement is a health equity issue. And not many people necessarily make that connection naturally, right? But given the volume of people that depend on government policies, government healthcare policies to get their coverage, large gaps in coverage of new technologies tend to hurt the underserved.
Correct.
Right? People who don't have access or don't have information or don't go to the doctor as often as others. And oftentimes in Washington, people tend to think about it just through a budgetary lens. It might cost more money. Well, it might cost more money, but it also might save millions of lives if you get it right. And sometimes I just get frustrated they don't make that connection. It's not the wealthy and healthy that are impacted by the lack of coverage, right? It's the poor and the sick that are negatively impacted by the lack of coverage and reimbursement. And that's what the federal agencies need to better understand, I think.
No one is suggesting you should throw money after bad technologies, that you don't need data, that you don't need to demonstrate some value, that it works. You obviously have to demonstrate that it works. But there needs to be a path that gets you to where you can deploy this into the real world and collect data along the way. If you sort of have two options, right? You get to a point where you have a certain threshold of data that says, okay, this thing seems to work. It looks like we can have an impact. We can save lives with this. We don't have tens and tens of thousands of patients, but we have enough data where we can reasonably think that this is going to work. So let's deploy it to large populations and collect the data along the way. Is there a possibility that 10 years from now, it was the benefits were overstated and so forth? Sure, that's a possibility. And it should be a continuous process of making sure that we should be assessing the economic and clinical benefits of technologies on a continuous basis. That's sure. But the alternative, which is to just say, let's wait, and say, let's wait till you have 100,000, a clinical study with 100,000 patients that shows this to a p-value of 0.005, and then we'll offer this to the population. In that interval of time, thousands of patients are going to die. You know? And so there's a middle ground. It's not that industry or innovators or companies are asking for a free handout. We just need sort of sensible, reasonable thresholds that are balanced by the fact that these are often life or death things.
And not to mention there's a doctor at the end of this equation as well, right? Who's going to make an informed decision on whether the patient should have access to it or not access to it based on, you would hope, some pretty good data. But doctors aren't going to just throw something in someone just for fun, right? I mean, there's a reason why they would recommend it. And to some degree, you need to trust the physician in this process as well. I said to a friend who's a regulator recently, there's a lot of risk that's taken on the front end of these to develop these technologies. And yes, there's some risk you'll have to take too in covering them. There's no 100% certainty. But if you're going to err on the side of giving access. Don't err on the side of denying access, right? And that's oftentimes not what the decision is, but what it should be, at least in my opinion.
It should be a partnership. This shouldn't be an adversarial thing. So you say, give access, and we'll work with you to make sure to develop the data, to make sure that it's being utilized. We've had conversations with our diagnostic tests with a whole bunch of payers, and we're like, look, we can control who gets the test. We can make sure that we can track to make sure that there aren't rogue physicians out there ordering our test in 20-year-olds where there's no business doing so. We can go at risk with you. And in terms of structuring arrangements, all of those are on the table. We just need access. We just need to be able to kind of cross a certain threshold and get access to the patients. And you're right, give physicians some respect to the fact that physicians will generally make well-informed decisions, have some understanding that we understand the biology, and acknowledge that it may take some time to get large population database understanding of this, but we can work together along that path. And so, those are the conversations we certainly have to have.
I think that's it. I think one of the areas we've made so much improvement on with FDA is they recognize the value of the public-private partnership. And not always do public payers see that same value. And the more collaboration that occurs, the more transparency that occurs, the more predictability occurs, the better the outcomes are going to be for patients almost every time. Right? And there's just so much value in that. I wish they would embrace it a little bit more.
But hopefully it took a while to change the dynamic in our relationship with FDA.
It did,
And hopefully that, there's certainly some signs that we will do the same. I don't want to let the private payers off the hook, by the way, because they do tend to use Medicare as an excuse. And so it's not uncommon that they're like, well, Medicare, we'll wait till that. It's a convenient, it's sort of a convenient, it's not universal, but it can be an issue. But there are things that the Medicare and the public payers can learn from the private payers, which are, they're not throwing money away either, but they have programs. I mean, coverage with evidence development is a very well-established process on the private side where you agree. It's really a true partnership, right? You say, okay, we might not have enough evidence for the utility of this particular technology to satisfy you yet, so let's work together to develop that, but understanding that you need to have some skin in the game in order for us to reach that point. So there are models on the private side that the public side could adopt and learn from.
Well, thank you for coming on the podcast. It's been a great conversation. We've covered a lot today. Heart health, cancer, innovation and coverage as well.
We certainly have covered a lot of ground. It's been really enjoyable, Scott. Thank you.
Thank you for your service to AdvaMed and the role you play here. It's very important to us in the industry as well. So,
great. Thanks, Scott.
Thanks. Good to have you. Thanks again for tuning in to the Medtech POV Podcast. For more episodes, visit advamed.org/podcast or subscribe to Medtech POV on your favorite streaming platform.